Good afternoon and welcome to this webinar about a rare disease. My name is Dr. Christina Lampe and I'm the director of a rare disease center at the University of Giessen. But I will talk about my exciting journey of my business life a little bit later. Today I would like to speak a little bit about a look at the last 10 years in MPS management, in particular in MPS II, and also called Hunter syndrome. These are my financial disclosures. So for this, I would like to present you two cases, real cases to show the difficult diagnosis, the delay of diagnosis, and also the management of these patients. To start, I will give you a very short summary about MPSs. And MPSs, or Mucopolysaccharidosis, are lysosomal storage diseases, and they are a group of 7 rare genetic, metabolic, and, as I said before, progressive diseases. All MPSs are inherited in a recessive pattern. MPS II, in contrast to that, is X-linked. The cause of the disease is a storage of glycosaminoglycans that are not degraded due to an enzyme deficiency in lysosomes. So, and since the glycosaminoglycans are the main component of the extracellular matrix, you find GAGs everywhere in the body. And this is the reason why MPS diseases are multisystemic diseases. And actually, these patients can have a reduced life expectancy. On the right side of the screen, you see the different types of MPSs, but in particular, we speak about Hunter syndrome today. But before we start going into detail about the diseases, I would like to give you a short introduction to my career in this very interesting and exciting field. I started my medical school and finished my medical school at the University of Berlin, Charité in Germany. And I worked as an intern and also as a consultant at the surgical department of the University of Berlin as well. So my first 7 years, I started in a surgical field. By chance and due to a movement to another city, I started working at the Department of Pediatric and Adolescent Medicine at the University of Mainz in a very special working group, a working group only for lysosomal storage diseases. And there I was the first time involved in metabolic diseases or such rare diseases. In my time as a surgeon, I never heard about MPSs. I was not interested in metabolic diseases at all. And actually, I was never thinking to any metabolic diseases. My only interest was to cut and to send the patient away after. But I learned in that time that it is extremely interesting to follow these patients in a multisystemic manner. And actually, these patients need a real care and physicians that know about the diseases. And so I founded with a colleague and worked as a vice director of a center for rare diseases in Wiesbaden, Germany. And in October 2018, I started as the director of a center for rare diseases at the University of Giessen. And I'm very happy about that. It is not only to work with these patients and to treat the patients, but the rare disease field is very exciting and interesting and rewarding. It is not only to work with patients, but also there's a lot of work in research. You can publish papers, you can work as a co-author in many recommendation papers. You can perform clinical trials to approve new medications for these rare diseases or rare disease patients. I'm an investigator of the MPS II Hunter Outcomes Survey, HOS, which is a registry, a worldwide registry for MPS II patients to learn more about the disease. I'm also part of different working groups and also part of the patient organization as a medical advisor. So today I'm a webinar presenter telling you that such a rewarding career in rare diseases could be yours. It just starts with that moment you devote to really listening about the MPSs for the first time. Making a diagnosis means that you detect a disease that is progressive and life-threatening. But for patients and parents, it is extremely important to have a diagnosis, to find an expert center, to know which treatment is available, and also which treatment is necessary and which treatment is not a good treatment for these patients. You can hear about new treatments and also to avoid that you are treated in a wrong way. So, to start with the case report of a difficult diagnosis, I will present you a case that is a very typical MPS II case. You will see the unspecific, but in combination, typical for MPS signs and symptoms, and at the end, the diagnosis that is made. It is indeed difficult to make a diagnosis in MPS patients due to the progressive and extremely heterogeneous manner of these diseases. It is no universal, specific Hunter syndrome symptom. Unfortunately, this makes it difficult, but the combination of unspecific signs and symptoms lead to the suspicion. These unspecific signs and symptoms are, for example, recurrent airway infections or inguinal hernia and umbilical hernia. These are typical, but as I said, unspecific things. So the onset of MPS II signs and symptoms can be insidious as well, and there's a large overlap between signs and symptoms of MPS II and common childhood complaints. This makes it difficult. So, in summary, to detect MPS II, the clinician must take a holistic approach and not just focus on a single sign or symptom. This means also that physicians have to work together in a team to make a diagnosis. So, whenever you have a patient with multisystemic organ involvement, take a step back, look at the entire clinical picture to recognize a genetic syndrome. Now I will start with a video to show you a typical MPS II case and the diagnosis. This is Tim at his first week of life. It was an uneventful pregnancy and birth. He was born at normal height and weight and considered as a healthy child. The only thing that was a little bit strange was that he had a slightly enlarged head circumference. And you see him here, and he's looking absolutely fine and healthy. This is Tim at his second week of life, and you see him showing his first smile to his parents. And at the age of 5 months, he had already an inguinal hernia repair, even if he was born at normal gestation age. And it was still noted that he had an enlarged head, and he started to have recurrent infections of his airways. You saw him sitting with 7 months, very normal, and he was able to turn around from the back to the belly at the age of 9 months. You see him here with 9 months. He started talking with yeah, 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 so the typical first sounds that a baby is doing. And with 10 months of age, you saw him that he had already the first recurrent infection of the airways and needed antibiotics. And with 11 months, you see him here, the parents realized that he is not speaking properly and that he is, in a way, looking completely different from the rest of the family. With 13 months, he was starting to walk his first step. And here you see him with 15 months walking alone. You see him here with 23 months of age. He had several problems with hearing and ENT surgeries in that time. He needed ENT surgeries because he had a hearing loss, and nobody was really sure why he had this hearing loss from. So he was not starting to speak, but the parents thought it is due to the fact that they spoke Spanish and German at home, and they insisted to go to a physician to to get some diagnosis for that. With 27 months of age, he went to the kindergarten. You see him here. He is cleaning the table, and you see also his face that is changing in that time. With 28 months, you see him with the father in the swimming pool. You see the enlarged abdomen, and you will see him also when he's walking, that he looks very stiff, that his back is very, very straight. And what you also have to know is that this patient had his second inguinal hernia repair, this time on the left side at this time. He was still suffering from recurrent infections of the airways and had another ENT surgery. His head was still a little bit enlarged. It was performed an ultrasound, but nothing pathological was found beside the size, and nothing was done anymore. At this age, with 30 months, you see him here eating. He was not communicating very much, but he was very active in communication and in social life. He was tired very often. He was sleeping badly because he had some breathing problems. The parents reported that he was very clumsy and he got tired very quickly. He had this enlarged abdomen and head. He had coarse facial features and still the recurrent and severe airway infections that needed antibiotics several times. And actually his parents insisted on further examinations, which confirmed as the first diagnosis with a child neurologist, developmental delay, especially focused on speech. The child neurologist, who had already seen an MPS patient before, was suspecting MPS and started some diagnostics, a Berry test, which is not valid nowadays anymore, but it was a start. At the same time, the parents sent the photos of this child to the geneticist to Germany, who immediately, due to the coarse face and the symptoms he heard, had the suspicion of a Hunter syndrome, or at a differential diagnosis, an alpha-mannosidosis. At the end, the diagnosis was confirmed at the age of 30 months due to an enzyme activity testing and also confirmation of a genetic testing. And here you see him with 31 months of age. So to summarize this case, the children, and this is very typical for MPSs, are born at normal height and weight. Like healthy children, they are even more proper than others after uneventful pregnancy. The only thing which has to be mentioned is the slightly enlarged head circumference in that child. I'm sorry for that. So, what is the next step? He had inguinal hernia repair at the age of 5 months, which is not usual for healthy children that are born at a normal age. He had the enlarged head and the recurrent severe airway infections. And you see also on the photos the change of his face. The development was quite normal, beside the fact that he was not crawling. His teething were a little bit delayed, and he had the language delayed due to the hearing loss that was noted. He had also, at the age of 2 years and 3 months, the ENT surgeries and an inguinal hernia repair on the left side. And you see also the enlarged abdomen with the umbilical hernia at the age of 18 months. Further symptoms that were shown between the age of 2 to 3 years was that he was not sleeping well, clumsy, tired very quickly, enlarged abdomen and head, coarse face, severe airway infections. And actually, the parents insisted on finding a diagnosis. The mother was pregnant before he was diagnosed, and they were really pushing to find a diagnosis, to understand what they have to expect also for the unborn baby. The child neurologist who suspected MPS started the testing. Also, the photos shown to someone who knows about MPS raised the suspicion, and the diagnosis was confirmed in that patient. Also, the X-rays that were done before shows some typical signs and symptoms that I will focus on in the next case. But the hip dysplasia and the stiff chest cage is very typical for MPSs. So if you want to start a diagnosis in MPSs, you can start with some screening tests or the urinary gag excretion in urine or the gag excretion. The problem in that test is that there are some patients missed due to the fact that milder affected patients don't have increased gag excretion, and also adolescent milder affected patients have sometimes normal range of gag excretion. A better test, a better idea that is available in most countries is the dry blood spot test measurement with enzyme activity measurement, which is a filter card where you put 5 drops of blood and it will test it. This test is very sensitive but not that much specific, so you have some false positive results, but then you can make further diagnostics to exclude or to confirm the diagnosis. The gold standard of testing is the enzyme activity measurement in leukocytes of fibroblasts, and confirmed will be or can be the diagnosis with the genetic testing. This is extremely important, especially for Hunter syndrome, because it is X-linked, and you have to rule out also the mother as a carrier of this disease for the family planning. If we now see the common signs and symptoms of Hunter syndrome and compare it to the signs and symptoms that we saw in Tim at the age of 30 months, we see that he has quite a lot of similarities, and most of these signs and symptoms he's really sharing. So this is really a very typical MPS II case. Another problem in MPSs is this case was diagnosed quite early, and usually between the first signs and symptoms and the diagnosis we have a delay of 1.5 years, which is quite long. This is what we know from the Worldwide Registry for Hunter's disease. But I would like to show you also that the diagnosis is often delayed, especially in patients that are non-neuronopathic, meaning that have no cognitive involvement. Especially these patients, the symptoms are more subtle and the disease onset can more insidious. So these patients are often delayed in diagnosis. So again, I repeat myself, but if you suspect MPS II, refer to a medical geneticist or a rare disease specialist for diagnostic to confirm, because in some countries there's a treatment available. And even if there's no treatment, the follow-up to detect the quality of life reducing disease complications as well as the life-limiting disease complications is extremely important for these patients. So this case, it's Heiko. He had a normal, uneventful pregnancy as well. He has 2 healthy older sisters and was born at a normal height and weight. The mother actually noticed, in comparison to the older sisters, that he had a kind of stiffness of shoulders at the age of 3 to 4 months, and crawling was not possible. But none of the physicians realized that this is a real problem. At the age of 2.5 years, he had an ENT surgery, and the anesthesiologist detected the contractures of the joints during the preparation and suspected a storage disease. Actually, nothing happened that time, and at the age of 3 years, he had another ENT surgery. He had a language development delay, as the other case that I presented, due to a hearing loss, and went to a special kindergarten. At the age of 4 years, he had an inguinal hernia repair, and actually at the age of 4 years, so 2 years after the first signs and symptoms and the suspicion, the diagnosis was made and confirmed by the genetic testing. At this time, he had also an umbilical hernia, a splenomegaly, the coarse face, totally looking different from the other family members, a worsening of the stiffness of his joints, claw hands, knock knees, but no neurological finding. At the age of 6 years, he had another ENT intervention and also an extension of the tendons of his legs, which is a good possibility for a lot of diseases, but totally useless for MPS patients. This shows how much important it is to find a diagnosis earlier. At 7 years, he lost his height percentile. He had severe joint contractures and also some problems in the nonverbal intelligence testing because of the disability to perform the test in a proper way. And he started to have also some heart involvement at the age of 8 years. Between 8 years and 12 years, he was not checked by any surgeon, any expert or physician in a follow-up, so he totally disappeared from regular checkups. And with 12 years, his height was on the 10th percentile, and he was born at the 90th percentile. So he really, his growth was slowing down, cardiological situation was stable, but he also suffered from a restrictive and obstructive lung disease. He had increasing contractures of all joints, so it was not even, it was very difficult for him to hold a pen to write at school. Also walking was difficult. He had a hip dysplasia and the severe knock-knees. And there we come to the musculoskeletal symptoms of MPSs. You see him here, prior surgery with severe knock-knees that were beside the contractures, making it difficult for him to walk properly, and with a very short and small intervention, surgical intervention with 8 plates, he was corrected so that after 1 year of surgery, you see that he has straight legs. Now it's between 16 and 17, he stabilized due to the fact that he was on standard care treatment that time, but still the contractures are there and influencing his life. But he's working as an IT specialist in a hospital now. Here, if we see the signs and symptoms of MPS, we see that he is not that much affected as the other boy that I showed you. He has mainly a musculoskeletal involvement, but also the ears are involved, the heart, and the gastrointestinal, and the appearance, but not as much as the other case. The skeletal changes in MPS patients are also called DYSOSTOSIS multiplex, which means these are radiological signs that can help to make a diagnosis of MPS patients. These skeletal changes also are the reason why MPSs are not only metabolic diseases, but they are also part of the skeletal dysplasias. So we have 46 groups of skeletal dysplasias, and one group is the DYSOSTOSIS multiplex group. So also in this field, this, you can see MPS patients. What is a DYSOSTOSIS multiplex? Beside the hip dysplasia, the oar-shaped ribs, the shortened sternum, and the short and thick clavicles, you have also the flattened vertebral bodies. So they are ovoid, so you should see them. You have shortened metacarpals that you see as an appearance as claw hands, etc. So there are many signs that are called DYSOSTOSIS multiplex. So all parts of the body are involved in the musculoskeletal alterations, not only the spine and the upper limbs, but also in general, patients have a normal growth following birth, but then they are slowing of growth, as you saw in these patients. They have the joint contractures, the ossification delay, and, for example, on the upper limbs, trigger finger and carpal tunnel syndrome, deformity. In literature, if you see here this table and you can compare the different MPSs with each other, what you can see is that the MPS II patients have a joint stiffness, and they share this feature with MPS I, a little bit with MPS III, but also MPS 6 and 7. So I call this group because from the appearance, you cannot decide between MPS 1, 2, 6, and 7, but I call them the stiff ones. So the stiff MPSs, while the MPS III patients have some joint stiffness and musculoskeletal involvement as well, but they are much more, or their main feature is the cognitive decline in childhood, a kind of dementia in childhood. And in contrast to that, we have the MPS IV or MOCU patients that have a hypomobility of joints. So they have a joint laxity that is the main feature in these patients. So since we know we have a lot of musculoskeletal involvement, so a lot of surgeries are needed, even also the ENT surgeries that these patients need. We have to manage these patients who require surgery, and we always have to check whether a surgery is necessary or if the anesthesia complications are higher. So we have to balance. What we know is that in a cohort of patients with MPS I, II, and VI, 70% had intubation difficulties due to the fact that the glycosaminoglycan storage in the soft tissues in the airway are narrowing the airways. In Horst, the Hunter Outcomes Survey, inside the MPS II patients, we know that in 22% of patients, and this is a number of 428 patients, had difficulty with intubation, and 4%, almost 4%, also with extubation. So even the perioperative mortality in MPS I is described with 4%, so quite high. So the anesthesiological risk factors in MPS patient is not only the difficult airway, the difficult intubation, and the equipment size that is unpredictable, it's also the short neck of these patients, the reduced cervical spine flexibility, or the atlantoaxial instability, which is extremely dangerous while intubation due to the fact that you can break the patient's neck. You have also the difficult positioning due to the deformity of the body, the contractures, the enlarged abdomen. You have in 70% of patients, Hunter patients, that have a cognitive involvement. You have also the limited cooperation of these patients because the best intubation is awake and fiber optic intubation. And you have also an involvement of the cardiorespiratory system, so limited resources of that system. So you have heart valve insufficiency, cardiomyopathy, recurrent infections of the airways, and the restrictive and obstructive lung disease that makes it difficult. So at the end, what you have to do is, in the postoperative planning, you need an intensive care, a very slow weaning, and to avoid airway swelling in these patients. How to manage now the MPS patients' surgeries? Important is to have a very good planning, and this is also why expert centers are so important, because not only the surgeon should know about the disease, also the anesthesiologist should know. So to check the cardiopulmonary status before any surgery, like echo and ECG and the pulmonary testing to test the lung. You need conditions to understand the conditions to intubate. So ventilation, is it possible? What size of equipment do you need? Has the patient an atlantoaxial instability that you have to take care of? So you need a laryngoscopy to check the airways and the MRI of the cervical spine and spinal cord. The conditions to ventilate, you never know whether this patient has a tracheal stenosis or Malaysia, and also the intraoperative positioning has to be checked. So the CT scan of the airways is very useful to answer this question. And also the conditions to extubate should be analyzed in advance. So early extubation inside the operating theater is recommended. In tracheostomy, stand by, so you have also to involve the ENT physician, and the ICU, the intensive care, should be there. So you have really to organize and manage a whole team. It is not only one physician who can do that. What we know in MPS II patients from the Hunter Outcomes Survey is that most patients had the first surgery before being diagnosed. And there were 18% of patients who had problems with intubation and almost 8% with extubation. So the prompt diagnosis is the key to implementing precautionary management. So again, I repeat myself, take a step back and look at the entire clinical picture to recognize a genetic syndrome. Thank you for listening to this webinar. There are more resources to understand and to learn more about Hunter syndrome, but by now I would like to start with some questions that you may have, and I will answer. And I hope I could encourage you to start in that field, to be excited, to start to work in the rare disease field, or at least to detect patients and to have the awareness for these diseases. So the first question is, how do you balance the life-threatening risk of surgery with general anesthetic versus the benefit of a corrective procedure of musculoskeletal symptoms of MPS II? This is a very difficult question. What I usually do is I send the patient to all these assessments that I mentioned, like heart, lung, airways, spine, etc. And I speak together with the cardiologist, the anesthesiologist, and also the orthopedic surgeon to understand whether the surgery or the anesthesia is of a risk that the patient has a benefit later from the musculoskeletal surgery. If there's a too high anesthesia risk, I would refuse the surgery and try to help the patient with some physiotherapy, with orthosis, and at least to see whether I can do something, pain medication, so with some supportive therapy. But this is one of the most difficult moments to know when a surgery is more important or the anesthesia risks are higher. The next question is, the next question is, what can you offer in case of a sleep disturbance? What is the initial drug of choice for convulsions? So I have to say, sleep disturbance is a big problem in MPS patients, especially in the patients with cognitive involvement. What we first do is we make a polysomnography to understand whether breathing problems are the problems that patients cannot sleep properly. So this is the first, and a lot of patients have indeed recurrent adenoids so that they are not breathing properly during night. And a lot of patients, even patients with a cognitive involvement, have a benefit from a ventilation mask during night. So this is the first. If I am asked about sleep medication, it is very, very difficult. The first I start with is melatonin, and it's difficult to find a dosage. So some patients need 2 milligram, others need 15. So this is something you have to try in your patient, because every patient has his individual disease and is individual. For seizures, it is difficult to make a general suggestion. If possible, I start with valproic acid, but there are also some epileptic syndromes that should be treated with other drugs, so I cannot generalize that. The next question is, do you think that's important that the anesthetist has MPS experience, or just that they have a lot of experience? It is okay if someone else in the room has MPS experience, such as the surgeon. Well, yes, if the anesthesiologist is aware of the disease complications and the airway problems of MPSs, I think it is possible that the MPS specialist is telling him and helps him to understand the situation. So everybody has to start from somewhere, and big experience in anesthesia is absolutely fine if there's also some recommendation from an MPS specialist. So I think this is the way to start from and to do it. You showed the next question is, you showed an early red flag symptom of MPS II was hernia. I see this every week in a pediatric patient. I can't be sending them all for genetic testing. What do you suggest? You're right. The hernia itself is not enough to have a suspicion of MPS. But if you have inguinal hernia in combination with umbilical hernia in a baby that is not a preterm baby, but born at normal age of gestation, and the child has, for example, some otitis or recurrent infections of the airways, you should think about. Actually, this dry blood spot testing is extremely easy because it's just a small filter card and you put 5 drops of blood on it and you send it out for a diagnosis. And a lot of countries have these tests for free from companies. So I think whenever you have a suspicion, you test. And if you don't find or you exclude the disease, it is even better for the patient. But the more we test, the more patients we will find. And I think that a lot of patients are missed at this early stage because we don't test enough. What advice would you give to a surgeon to help them recognize MPS? I think I started answering that in my last answer to the last question. Whenever a patient looks strange, different from other children, whenever he has in his medical history the recurrent infections, ENT surgeries, and hernia, you should think about. In older patients, I have to say also a carpal tunnel syndrome, which is not typical for childhood, would be a sign for MPS patients. So at the end, since genetic diseases like the skeletal dysplasias are so difficult to diagnose, but it is so easy to diagnose MPS with the dry blood spot test, I would say whenever you have a child with any musculoskeletal involvement, test on MPS, because in some countries there's a treatment available and these patients really need help. And if there's no treatment, at least the supportive treatment that makes their life easier. Next question is, with the possibilities of next generation sequencing and newborn screening programs, a possibility on the horizon, is there still a role in being a rare disease or MPS specialist? Yes, in any case, because it is not only a matter of diagnosing. As we saw in my second case, the suspicion was there at the age of 2 years. He was diagnosed at 4 years. At the age of 8 years, he disappeared from any physician, and he had his regular checkups in a specialized center at the age of 12. And since we have 5,000 to 6,000 rare diseases, it is impossible to know each disease in detail. So we will still need MPS specialists, not only for the diagnosis, but also for the management of these patients and the follow-ups. The newborn screening would be fantastic to detect patients early and to start also treatment early and to really have the follow-up at this age. But at the moment in some countries we have some pilot projects, but in most countries it is not available, unfortunately, so far. The next question is, thinking about your first case study of the child with many symptoms, seeing different specialists before they received a diagnosis, do you think that a certain number of unexplained symptoms or a certain number of fruitless referrals, rather than telling doctors to look for specific symptoms, should instigate referral to a rare disease specialist to find an underlying cause? Exactly, this is what I think. Whenever the parents say, my child is strange, there is something wrong with my child, or whenever you as a physician have the impression that there is something wrong, the best is to send to a specialized center or rare disease center. Then the children can be checked. They have mainly, these centers have the opportunity to make a lot of testings, but the patient has not to have the odyssey from one physician to the other. So the next question is, in the first case study, the parents said their child is always sick. I hear this a lot with parents worrying if something more is wrong with their child. Do you think that parents are often right? Sorry? Probably with their, has the internet made parents paranoid? I mean, this is something that I cannot answer. It is extremely difficult. But what I think is, as I answered to the last question, when we go from one physician to the other, we don't get anything beside the fact that we find one physician who knows about the rare disease. But if the parents are sent to a specialized center, they check it, they exclude, and they are, in a way, more relieved after. So I think we should listen to parents, but since if you are following some patients, you know the parents, you know how they react and what kind of, if they are more scared or more relaxed with their children. So, but better you send one time more than one time less. So I think nobody should send a patient away without a diagnosis. There's another question. What advice would you give to a surgeon to help them recognize MPS? I think this is a question I answered already. Are there any other questions? Because the questions I have here are already answered. Okay, then we close this seminar. Thank you very much for listening. I hope I could encourage you, engage you, and show you my excitement to work in that really rewarding field. And if you are diagnosing a patient, it would be fantastic because it makes not only the patient's life but also the family's life much, much easier. Thank you very much.